significant. And on the left side of the slide, we actually have the mortality rates. And you can see that, in fact, the highest mortality rates are still occurring in the neonatal period. And I understand that among us, there are many pediatricians and also, I hope, some neonatologists and some people that are working at around the time of birth, so that are really working in trying to dent those mortality rates significantly. If we can go to the next slide, it's important to focus on the number of deaths and explain that this significant progress that you see on the number of deaths between 1990, that were around to 12.5 millions, to the last year of registration by the UN IGME, that is like 5.2 million of deaths, has been a great progress that has spanned the time that we call the Millennium Development Goals, but also to remind ourselves that those Millennium Development Goals, and in particular the child mortality goal, called for actually a reduction of 2/3 of child mortality between 1990 and 2015. And in fact, the world did not reach that goal because the reduction that happened was roughly 50% of under 5 deaths in the world. So we have now, in the era of the Sustainable Development Goals, what we call an unfinished business and an unfinished agenda that really pertains to reducing deaths in children under 5. I also would like to draw your attention to the line with the green, that is the neonatal deaths, and you see that those deaths also have declined over this 25 years period, but not as significantly as the overall child mortality deaths. And then I want also to draw your attention to the light yellow orangey line, which are the deaths in adolescents. And you see that, in fact, the change in the estimates of the deaths has been very, very insignificant. And that's why since 2015 and 2017, globally, we have created a movement and much more attention for focusing on adolescent health and also adolescent deaths. Next slide. It's important also for us to realize that those deaths are not equally distributed in the world, because there are some parts of the world, the lucky ones, like the UK, like Italy, like some part of the developed world, where the death rate under 5 mortality rates is below 5. And there are instead several parts of the world, and particularly sub-Saharan Africa, in sub-Saharan African countries, when the under 5 mortality rates are still above 100. And you can see there from the intensity of the color where the deaths, the mortality rates are the highest. Next. Now, these slides that are taken from the SAY report is to focus on what were the predictions that we had in 2019, 2020, when this report came. And these predictions were actually not taking into consideration any COVID. We knew that a pandemic was possible. We had seen a pandemic before, H1N1, but we haven't seen, the world hasn't seen anything of the scale of COVID-19 since probably the flu pandemic during and after this First World War. So we were not really prepared. But if you see the projection that we had under the under 5 deaths, and you see that there were different scenarios, and really to try and reach the SDG target, the world needed to have some acceleration in the reduction of deaths, not a rebound, as you can see from the green slice that is the one that is for achieving the Sustainable Development Goal targets. Next. And I put this up because you can see that when it comes to neonatal mortality rate, the distribution in countries is pretty similar to the child mortality rates. And then to say that this, to remind us that in fact, if we want to dent really overall under 5 deaths, really where we have to focus very, very strongly is looking at the deaths in the first months. Next. Now, this is the second part of my what I want to share with you is COVID-19 pandemic. We are all been living since the beginning of 2020 in a different world. And when pandemic struck, to some extent, for many of us advocates for child health and adolescent health and women health, it was a hard time because immediately the alert and the pandemic response did focus on adults. And in fact, at the beginning, there wasn't really any focus on children. And progressively, we realized that, in fact, the pandemic does not maybe affect directly in terms of mortality children, but has a tremendous indirect impact. And I've tried to summarize some of the modalities through which the indirect impact of COVID-19 is affecting children. So the first point, this is taken from the UNICEF report on the COVID-19 impact on children, is about the poverty and the fact that this is not just a pandemic, an infectious disease, but is also a pandemic that has created significant falling into poverty of families. And it is estimated that more than 115 additional million of children are living in poverty without access to essential services. And those, of course, include all the health services that are so crucial for reducing child deaths. Those include access to vaccination services, include access to treatment for the common diseases of childhood, from malaria in countries where malaria is endemic, to pneumonia, to the important aspect of nutritional and nutritional advice. So the first indirect impact is the creation of additional poverty for families and for children. Next slide. Also, as you can see, this that particularly in developing countries, an estimated 140 million children are projected to be living below the poverty line. And that is clearly very, very worrying, because we know that there is a strong association in every single country in the world. And as you are a student of this, you know that there is a strong association between what we call the social and economic determinant of health. So there is a clear gradient of mortality across the socioeconomic quintiles. Next. This it's also an important indirect impact of COVID-19, which is in relation to learning and education. And you know that it's almost 500 million children that were unable to access remote learning during the school closure. And this has a tremendous impact on especially child mortality and child mortality rates, because we know, for example, that maternal education is one of the key social determinants of child health. And so the fact that children will not have access to this, and especially younger will not have access, is promising a significant impact on their own health and on the health of their children when they become parents. Next slide. This is, before you click on the starting, I want to say that because of all this indirect impact and because of the isolation and confinement due to lockdown that many countries have lived through, the Partnership for Maternal, Newborn and Child Health, together with other partners, have created some advice, especially for parents, to focus on what you can do as a responsive caregiver in a situation of a pandemic. And this is a very brief video that summarizes what you can do. Please go ahead and play. I'm not hearing the sound.
Family is often, and the COVID-19 pandemic is a challenging time for children, parents, and other caregivers. Working from home, school closures, not seeing friends and family as often, and financial insecurity has made it harder to provide the love and care that children need. Doing a few simple activities with your child can provide them with comfort and love during these uncertain times. With your baby or toddler, cuddle them. With your young child, read a book. Members, dance or sing together. With your older child, show interest in their hobbies and allow them to have positive interactions with people. With children of all ages, setting healthy routines for eating and sleeping are all important contributions that you can make. If you feel overwhelmed, take a break. Try a few minutes of deep breathing and time for yourself. You will be better able to take care of yourself and your child.
Thank you. So the other things, the last part of my talk, I really like to share some of the actions that advocates and particularly the Partnership for Maternal, Newborn and Child Health have undertaken during this time of COVID-19 to make sure that women, children and adolescent health is not forgotten and in fact continues to be prioritized by governments and by member states. And you see, this is one of the ways that we have done it, which is to create a call to action for COVID-19, and through which we urge governments to protect and promote the health, well-being and rights of women, children and adolescents through strengthened commitments, especially political commitments, through the policies and domestic resource mobilization and financing, because those services need to continue to be financed. And you see that the different 7 asks that this call contains touch upon different aspects of women, children, adolescent health. And there is one last pillar that I like to particularly stress because I haven't touched upon that yet, which is the prevention of violence against women, children, and adolescents. Because during this time, particularly in countries with strict lockdown, what we have seen has been an increase of report through the hotline of violence against women, violence against children and young people. This violence is both violence online, but is also physical violence, is also psychological violence. And we know that during time of crisis, like pandemic, this is a typical reaction because in situation of crisis, violence emerges even more. If you go to the next, this call was launched last year and it's part of a 2-year multi-pronged advocacy campaign in 2021 and 2022. And it builds on the messages and the work of the more than 1,000 partners that compose the Partnership for Maternal, Newborn and Child Health. This includes academics, includes healthcare professionals, including young healthcare professionals, includes a youth constituency that is very large and vibrant, includes private sector, includes very much governments and the multilateral systems, the United Nations, and therefore it's a platform that is corralling and mobilizing for especially country-led financial policy and service delivery. And we have had some success, if you can show the next one, because since this call was launched, we actually, you can see here the list of all the countries and the partners that have responded. And up to December last year, we had more than $20 billion that were pledged by all these different partners that are listed here. Some were financial commitments, some were policy and service delivery commitment. And this is especially, they made national response and recovery measures that included child and adolescent health. My last slide, so I'll able to stay within the time allotted, is to also bring to your attention another initiative that I think is very promising and is initiated by, is a new WHO, UNICEF and Lancet commission that was launched last year, and they are now calling for what they call Children in All Policy up to 2030. They call it CAP 2030. But it's the report that I really invite you to review and read, that is entitled A Future for the World Children, has a lot of focus on what is the impact of the environment and climate change on children's health. And you see, I think, this banner that the young child is holding, you'll die of old age, I'll die of climate change. And I think this is one of the key aspects that really, where I hope that we can have some joint advocacy and some joint work, including through the mechanisms that are currently happening, the Conference of Parties, the youth participation and pre-Conference of Parties that is coming up at the end of this month in September, and the COP that is happening in Glasgow in November. So this group is really calling for having a child lens that analyzes and underpin all the policies that governments put in place, from education to social protection policy, but also very much the environmental policy, as I mentioned just now. So let me conclude by thanking again the organizer and saying I look forward to the exchange and also to remain in touch in our joint advocacy to make the world a better future for the world's children. Thank you very much. Over.
Thank you so much, Dr. Bustreo. That was really good to hear about all of that as well, and some very alarming statistics, but also some very touching and very, very encouraging statistics and facts about the pledges and the funding that has been raised. So our next speaker is another very, very esteemed colleague and someone I actually have really a lot of respect for, which is Professor Mark Tomlinson, who is the co-director of the Institute for Life Course Health Research at Stellenbosch University. He is a professor of maternal and child health in the School of Nursing and Midwifery at Queen's University, Belfast. He has done a massive body of work on diverse range of topics, and it ranges from maternal health all the way up to child and adolescent development. And he speaks widely and advocates strongly for adolescent health. He's here today to speak about global child health and global child mental health in the time of COVID-19. Over to you.
Thanks, Adriel. Thanks so much. Can you hear me and can you see the slides?
Yes, we can.
Great, thank you. So thanks for the opportunity. It's really nice to be here and also to follow Flavia, who, as you'll see, touches on a few of the things that I'm also going to say, and it's a really lovely foundation for what I'm going to try and speak to. Just briefly. Okay, my slides there. Just to say, as Adriel kindly said, I'm the co-director of the Institute for Life Course Health Research, which is in the Department of Global Health at Stellenbosch University in Cape Town. And most of our research happens in South Africa, but increasingly we've been working in a number of other African countries, as you see there. What I want to try and start to do today is, I'm not going to give you a long list of the ways in which children and adolescents are struggling or not struggling. I'm going to touch on some of that, but I want to take a much broader view and hopefully touch on some of the issues which I think are really key here, particularly in the global south, in contexts where I am. But one of the things I think that COVID has shown, and the spotlight has shown, you know, on our world, is that there's vulnerability everywhere. And in fact, it's sometimes the richest countries seem to have a massive number of vulnerabilities that in many cases they probably shouldn't have, but do. And very often where those are felt is in mental health. And why I put these two slides on is that I'm a clinical psychologist by training, and there is a tendency in the mental health field to want to diagnose, to put people into fairly neat categories, and then medicalize the problem. Now, as I'll show in the course of this discussion and this talk, is that their categories, diagnoses are important. But I don't think they're as important as us taking a sort of a much broader and deeper view of why we're having such high rates, for example, of psychological distress prior to COVID, not just about COVID. Children and adolescents globally were struggling in many, many ways prior to this. And the danger of medicalizing it makes it then into solely a medical solution, and part of the solution is medical, but in fact part of the solution is also structural and it's political, and I want to just touch on some of those in this talk. So I like to think of distress, of mental illness, as much more of a continuum of what you would call a continuum of mental health needs. So on the one end, you've got people, children, adolescents, but also adults who they would describe themselves, and they would see themselves, and others would see them as psychologically healthy and mostly unaffected. And then as you start moving across this continuum, you then get levels of stress. Some stress, as many of you in this room as pediatric fellows and study, you know a bit about exam stress and how actually a little bit of that's quite good. It gets you motivated. You know, a little bit of cortisol going up is not a bad thing. The problem is when it's chronic, of course. When the stress becomes chronic and your cortisol levels remain high, that's when we're moving into the area of what we would describe as toxic stress. Then you move across, you've got these sort of subclinical cases, people who are moving along potentially to a diagnosis, but they're not quite there, and they move and they might stay there for a period of time, may dip into a sort of having enough symptoms, as it were, if you're going to give a diagnosis. And then you get sort of people who've now got a common mental health condition, depression, anxiety, whatever it is. And on the far end, you've got severe psychosocial disability. This would be psychosis, schizophrenia, the severe end. The thing about whether it's about thinking about caregivers, maternal mental health, whether it's thinking about children and adolescents, or anybody, in fact, all of us are moving at various times in a year in our lives, you know, at some point along that continuum. Most people will not get to that far end, but there's some movement back and forth. And if all we're doing is we're waiting for people to magically jump from this almost third bubble to the fourth one, where now we've got a diagnosis, we have a problem, because this other side can actually be quite distressing and in need of various things. It may not need a psychiatrist or a professional or a psychologist, but it might need it usually does need some form of let me say response. This was a paper that came out last year. It was a study that was done in Wuhan after their first lockdown, their very strict lockdown, the one that happened in, I think it was in February or so, beginning of last year, where the whole city of 12 million people was very, very strictly locked down. These researchers had got longitudinal, they'd done previous cross-sectional work prior to the pandemic with children and adolescents, measuring their psychological distress. And so they were interested to then compare what was happening to children and adolescents during the COVID pandemic compared to before. What they found was that, in fact, the rates were almost identical. that there was a slight increase, but certainly not significantly so in that increase. So the kind of the imagined distress simply wasn't happening. But having said that, and that's really just to point out that there's not a neat move from pandemic to distress necessarily for children and adolescents. But I'm going to talk about why it is we still have to be very, very worried and concerned, but that it's just much more of a complicated picture. And so I'm going to give some statistics, but I'm also wanting to make the point that sometimes we have this seemingly endless desire to get new data around, for example, a COVID pandemic. I'm a researcher. I want data. I want evidence. But the reality is we do know an awful lot already about what happens to the mental health of children and adolescents in conditions of stress. We know what happens, for example, in poverty with mental health. We know this is for adults. We know this is for families. There's both a sort of a social drift and a social causation, and what that means, and it's a cyclical. It's a they feed on one another. So you have people, for example, who live in poverty and have a mental illness, and because they have a mental illness, can't get work, and so their employment, so they drift further into poverty. You have people who have employment, then develop a mental health condition and lose their job, and then drift into poverty. And once they drift into poverty, then you have the cycle starting. The reality is that that's a very well-known and well-researched. There's a lot of data on that, done by in very long Lancet series by Craig Lunt and his colleagues. Now, the reality is, knowing that, we know that if people in COVID-19, if families, if parents, if caregivers are pushed into poverty, lose their jobs, we know the implications of that for their mental health. And when we know that parents are more at risk for mental health, we know that children then are at risk of emotional behavioral problems during infancy, during childhood, and then across adolescence. I would suggest that we don't need research to tell us that. I mean, I think we should be doing it, but the reality is we know that already. It's a well-known finding. It's highly unlikely that somehow being pushed into poverty because of COVID is somehow less stressful than being pushed into poverty for some other reason necessarily. So we have this, we do know these things. One of the interesting things in various studies last year, so in a UK study, looking at self-harm and suicidal ideation, there was quite a high level, as you see there. This is not amongst young children or anything, or early adolescents, but 18 to 29-year-olds, that 29%, almost 30% had self-harm or some suicidal thoughts during the pandemic. In a study by Vazard et al. In the UK, 43%, this is again last year, 43% of young people reported that lockdown had made their life worse. But this is very interesting. 25% reported that in fact it had made their lives better. Now that would obviously be a little bit of a surprise, but if one thinks about the numbers of children and adolescents in schools who are bullied, quite isolated, for them perhaps being at home wasn't such a bad thing. And I say that advisedly because I know that for many families, whether it's in the UK or globally, home conditions aren't ideal, and we know there have been increases in domestic violence. But simply saying that a lockdown and simply assuming that because of that the life is going to be worse for all children and adolescents, it may not be the case. So we just need to hold the complexity of it. In other studies, many children and adolescents complained, again, this is UK, of sleep disruption, of loneliness, and having increased access, in fact, at times to alcohol, gambling adverts, gambling online. Take a little bit of a step out. These are data. So the middle data is from UNICEF about class attendances during pandemic, and that there were basically 168 million children globally missing from school. I was part of a sort of a number of waves of data collection. This was done in South Africa during the course of last year and then into this year. And you can see the figures there of like an extra 500,000 children in South Africa who didn't come back to school in 2021. The implications of that for adolescent mental health is massive. We know that when children, particularly in low middle income countries, when they drop out of school, particularly in early high school or even late primary school, in many cases that means they're much less likely to return to school. And when they don't return to school, you know, outside of the obvious educational implications, future human capital implications, there's a massive implications for them then becoming involved in risky behavior, whether it's around substances or sexual risk, much more likely to become involved in gangs and develop various behavioral problems, and a higher likelihood of then, for example, later becoming being incarcerated. So that has massive implications, and we should and we must do the research on how to get those children back into school. But the reality is I don't need data now to know that has potentially massive implications for child and adolescent mental health. And I think the figures are quite similar for many countries in Africa. Another issue to think about when thinking about mental health is that of loss. You know, in low middle income countries, there are about 14 million children currently today that have lost one or both parents to AIDS. And again, there's significant research on the impact of that on children. An estimate from the paper that I put there on the right is that by the end of April 2021, 1.5 million children will have lost a parent or a grandparent caregiver, not just any grandparent, but a grandparent who was primarily involved in caregiving to COVID. And again, we know the implications for losing a parent. I think Flavia touched on that early. That has implications for child survival. It has massive implications for the education, particularly of girls. And again, we know the ripple effect of that across generations. This is a very interesting debate paper that was published. Sorry, I've got a preprint version of that rather than the published one. I think I'm sure it has come out by now. This is really about the UK, and I thought I'd put this just for people in the UK. This is a really nice paper. It's a commentary on some of what I was trying to get at around, is there actually a mental health crisis? Is it fact or fiction? And what do we really need to be worrying about? And I thought that might be of interest for some of the listeners. So I want to touch now on some of the structural issues, and then move into, and I'm sure I'm running out of time, but to then some of the issues about way forward. Is what COVID has done, and I think for people like me living in a country like South Africa and doing work in low middle income countries, the light that's been shone by the pandemic on the existing breaks, fissures in society are fairly, have been fairly apparent. It's not a particularly new phenomenon. It's been catastrophic in a country like South Africa. We have an estimated 250,000 excess deaths since the beginning of the pandemic. The official death figure of mortality from COVID is I think at the moment about 85,000, but that's hopelessly under, that's certainly not what it is, which makes South Africa, in very similar in terms of being hit hard as the UK and others. And this book on the right is a recent book, and it's a book I'd highly recommend. It's as much as in one of the reviews I read, the reviewer said the authors themselves appear quite inflamed, and it is to some extent a polemic of sorts. But what they're saying is that what COVID has done is, for example, if we think about the illness, we think about the inflammation that happens in various illnesses. We know that there's increasingly a link between inflammation and depression, for example. And we know that people who, who experience inflammation of one form or another, much more likely if they were, infected with COVID to then die. And the authors are speaking about what it's shown about how we've structured our societies and how the vulnerable keep on carrying the biggest burden of whether it's COVID or whether it's lack of access to healthcare, whatever it might be, and that the solution to much of it is not solely medical. In fact, I suspect the two authors here would say it's not even predominantly medical, of course, but that we need to think very deeply about vulnerability. And so a couple of thoughts is, and I've touched on some of these, is I think we have to see children and adolescents as moving across, across this continuum, and to not excessively medicalize this. We know that mood fluctuations, for example, as well, are part of perfectly normal processes of child and adolescent development, whether that's, tantruming young child or a typical adolescent going, and we have to find ways to see where young people are on that continuum, how they may move back and forth on it, and how they may need different support according to that position. I think children and adolescents are particularly important with regard to mental health, in that the enabling environment, their family, their caregiver makeup is generally, and it should be, it obviously is not always can be, but that really needs to be the first port of call, as it were. That's the environment in which children are held and contained, and much of the potential distress of anything like pandemic can be contained within the family. Now, obviously, we also need containment and assistance from schools and services, but the family is the first port of call. And what I think pediatricians and many professionals, one of the important key roles to play is to understand where children and adolescents are on that continuum. Who's the most vulnerable? And when the children and adolescents are the most vulnerable, what do they need? What sorts of referral do they need? Which children actually the family can contain it? And then what can be done to strengthen the family? And then which children actually will be okay? There's a piece of research I often talk about. I've actually over the years forgotten who initially published it. I think I heard it from Michael Rutter at a presentation of his, but I could be mistaken. And one of the theories was if a 10-year-old child loses a parent, kind of in a stable family, one of the parents dies. The hypothesis, of course, is that that's really obviously it's difficult, but it's a risk factor for future poor development in that child. But what they found with the research is when the remaining parent keeps it together, doesn't lose their job for financial reasons, or has a job and doesn't lose it, for various reasons is able to keep the child, for example, in the same school and make as much of their environment stable, those children are actually fine. When in fact it becomes risky for children is when the breadwinner dies and the other parent is unemployed and there's a drift into poverty. When the family, because of the loss, has to move cities, move towns, and move schools. We know for children, particularly in early adolescence, moving schools is an enormous risk factor, particularly if there's more than one. And so again, it's not the event itself, but it's this enabling environment that holds it together. I was involved in this document that was published this year. It was finished last year from UNICEF, and it looks at some of the lessons we have from past crises. And this is a busy slide, but I wanted to touch on some of it. Is that it's very easy, as I keep harping on, that it's not about a diagnosis and a single diagnosis only. We know, for example, or a single condition like COVID, for example, we know that there were massive pre-existing problems around poverty, mental health, social conditions, infrastructure throughout many parts of the world. Of course, in COVID, there's immediate impacts, such as education disruption. I've touched on that. Reduced nutrition, that's been a massive issue in many low middle income countries. And then obviously there are proximal impacts around distress within the family, community issues, and obviously government macro issues. And then this is where I'm the most worried about, I think, is the protracted nature of the pandemic. The fact that most of sub-Saharan Africa, no country, I think, is other than South Africa, is above a 3% of the population vaccinated. The extent to which this pandemic can roll and continue, that's where I'm most worried in terms of long-term impacts, often because of the structural concerns, but structural issues, but also about long-term impacts on parenting, obviously long-term health problems, and then deepened long-term recessions and the unemployment and poverty issues that come with that. I'm going to ignore that, and I'm again a busy slide, but it's been recorded, and I'm happy to share the slides. This also comes from that UNICEF document. It really is about all the different platforms, and one of the issues, and we in public health, it's the notion of universal provision. So what does everybody need? Antenatal care. Every pregnant woman needs antenatal care. It's a universal provision. Then we need targeted care. Which groups, children, adolescents, which parents need targeted intervention? So a caregiver with, for example, depression. And then indicated interventions, and that's to the smallest group. It's to the most vulnerable. It's often children with disabilities. But how do we start thinking in terms of universal, targeted, indicated as a public health response? Because then we're also talking about, by definition, prevention and not only cure and treatment. And again, I'm very wary of time, and so I want to rush through this. I don't want you to go through each of them. It tries to give a sense of all the different platforms, kind of where we may need screening, what should be universal. And so, finally, I think, as I've just said now, I think promotion, prevention, and early intervention are key. For children and adolescents, the family is the core resource. Schools are also core resources, and those are the institutions, the place that builds resilience in children and adolescents across the life course. So how can we create more enabling environments, or link families to the help that can create that more enabling environment? Because we know that, and Flavia shared that lovely video, but having a responsive caregiver and family is hugely protective. I know this is for a pediatrician in a private practice. Basic services, urban planning, social assistance may not be the areas in which you may be, intimately involved. But I think it's utterly key. We don't talk enough about the structural. We tend to make it clinical, individualized. Some of the work that Flavia shared around the Nurturing Care Framework, this is a framework that the WHO has developed, that I was part of developing, captures some of the complexity, both of the universal, the targeted, but also all the different things that children and adolescents and families need. And a point that, and this is increasingly an important one, is that children are not simply passive recipients. We have to recognize and support children's agency. It cannot be anymore that we are doing things for and to children and adolescents. They need to be part in a very kind of reciprocal, equal power as far as possible situation, where they're the ones who are going to have to live with the kind of the rather messy world that those of us of my age have created, and they have to be part of the solution. And this is a quote that I love. It's actually from a book about preschools, in fact, written by an amazing writer around early children and education. And the quote from Eric Christakis is, "The environment is the curriculum. Fix that." And I would say we can't leave all children just to thrive. Some children do need more, but we can certainly leave most children to thrive, and we have to do that. And then thanks Flavia for the pitch for the Children in All Policies. There's a nice, interesting documentary film made as part of the Lancet Commission on the Future Child, and this attempt to argue that children should be part of pretty much all policies, that their interests should be considered. as much as anyone's, and if possible, even prior to that. And we can see in the COVID pandemic how that absolutely hasn't happened. And in many cases, children's long-term public health needs have often not been part of the picture. And I'll end there. Thanks for listening.
Thank you very much, Professor Tomlinson. Striking while the iron is hot, I'm just going to start with Neil Russell's question here. Would the speakers agree that children's needs have generally been deprioritized in the process of responding to COVID in most countries? Are there many examples of countries that actually responded to the pandemic while genuinely prioritizing children's needs?
Shall I start?
Please do, Dr. Bustreo.
I absolutely agree with the comment. I think, as I said earlier, especially in the first few months of the pandemic, there was clearly a neglect of any issue related to children and to women, I would add, because the focus was really on adult men and also on the elderly, where clearly the mortality rates from COVID were higher. And was also related to the fact that in many countries, and we have written that and published in the Lancet, in many countries, the composition of the task force that were set up for dealing with the pandemic was completely gender unbalanced. Female participation to those task forces was very limited. And that was seen as, like my own country, for example, Italy, in the first task force that was set up, out of 20 individuals that were advising the government, there was only one woman. And she was actually the Undersecretary for Health. And she said anytime that she tried to raise issues that were, for example, in relation to schooling for children, in relation to those important transitions of the continuum of mental health need that Professor Tomlinson says alluded, every time she brought up the issues of domestic violence, those issues were not wanted to be discussed because the focus was on reproduction rates, access to services and intensive care units and all of that. So I absolutely, to my knowledge, I don't think there is any government any country that has really done well for children, but there have been some countries that, for example, have been a little bit more attentive to the need and supportive of the domestic violence. For example, France is one of the countries that comes to mind, where from the beginning, early moments of lockdown in the pandemic, they made available, they made a policy and then also a clear effort to make available hotel rooms for families where the explosion of the domestic violence was not able to really be managed, and they also supported women to have access to those hotel rooms. Some countries also in Latin America, like to say, they have experimented and used these social protection instruments that they were already in use, but those instruments, they have some, like for example, Bolsa Familia in Brazil or in Mexico, the instruments that they have had for many times, those were conditional cash transfers that were actually cash transfer to support families in poverty. And we have seen the impact of COVID-19 on poverty lines in many families in the world. But they were also conditional to the fact that the cash was given into the hands of women, and also conditional to the fact that these women would access healthcare services for themselves and for their children. So those are the two examples that come to mind for the second part of the question.
Maybe I can, I completely agree with Flavia there. I mean, I think what people have, what hasn't happened in the COVID pandemic is that public health is always about balancing risk against benefit. There's no only benefit. There's not. And in terms of children and adolescents, they were never on that scale. The scale was largely mortality and the economy. That's what they were. That's where the balances took place. And children was simply not part of it. I mean, I've read the most absurd things, for example, that infants don't worry about masking infants because infants don't need to see faces. Really? 40 years of research would count as some of that. And an infant and a toddler, and some of these instructions to, for example, mask a toddler can only be written by somebody who's never tried to put a mask on a 2-year-old for 8 hours. Some do it, but and so I don't think that it's been there, and I like the one point I just see in the questions about having children and adolescents on advisory boards. I think that's what we need to do, and I assure you, everybody there, that they will surprise us. We had a presentation with people as part of this CAP that Flavia was talking about, and Helen Clark, the ex-Prime Minister, was one of the speakers. And we had a young activist, 15-year-old girl from South Africa. She gave her written talk, which is lovely. She was incredibly, she's confident, she's amazing. And then we opened for questions, and I was one of the organizers. And then Helen Clark said something, and she said, "Can I just jump in?" And she said, "With all due respect, I have to disagree with you," to Helen Clark. Now, I'm not sure I would do that, and so my heart felt whatever. And she had the most spot on, polite, perfect. And Helen Clark loved it and said, "You're right." And, they will surprise us. They should be there. And we're the blockage, it's not about whether they can or not. I mean, obviously some can't, but they will surprise us and they have to be there. Yeah. Thanks.
Great. So you've both talked a lot about, about getting, Professor Tomlinson, you've emphasized that getting youth involved is really important when it comes to getting a stakeholder involved in decision making. In terms of enabling environment, what can we do to help adolescents and young people get a foot on the table? For example, in Scotland, we've had 16 and 17-year-olds have the right to vote. And do either of you think that's actually changed political outcomes for child well-being, especially during the pandemic?
I'll ask you to start, Mark, so we change the order.
Okay, thank you. So look, I have the deepest respect for Scotland's attempt to, because I think if there is a country in the world that's trying to put children and adolescents and their needs at the center of policy making, it's Scotland. I think that's laudable and important. The idea of an arbitrary cutoff that a child somehow at 18 can now vote, but the day before couldn't, is well nigh absurd. And I'm not advocating that 5-year-olds should vote or 2-year-olds, but I think there's no single answer to any of this. It's about one of the key components, for example, the 2 key components of the Lancet Commission on the future of the child. One of them was about harmful marketing directed to children. Children are being pulled into a lifelong consumerist, from the cereals they're eating with massive amounts of sugar when they're 1 year old, to all the things that up later into the online gambling. So that has to be controlled. Early access to alcohol. It's about strengthening families, whether, as Flavia said, in many countries, in low-income countries, with cash transfers to, when you don't know when the next meal's coming from, where you're struggling in a condition where there's interpersonal violence, the capacity of anybody to be able to provide really responsive caregiving to a young child is massively diminished, and that's not the fault of the parent. It's the condition. So we have to change all the conditions. We have to, when we, the example I often use is somebody said it once to me, as someone in the Western Cape where I'm based, the province here around. They were trying to get a really multi-sectoral thing going, and so the health department was meeting with the roads department. Now you wouldn't immediately think that's a usual kind of marriage, as it were, but they were trying to change the name and say, let's not talk about roads, let's talk about connectors, because they were saying the first thing that a road should be doing is connecting people to the health system, for access, people to their jobs, people to one another, and then also the commerce that goes with the road. But like, let's put people first. Let's, to quote my favorite anarchist, David Graeber, we have to have an economy that's based on care, first and foremost, care for people. And I'm not under any illusion that we don't need any thriving economy to be able to do that. But that at the moment, whether it's care for children or care for people, those are not at the forefront. And that's part of why we're in this mess around climate breakdown as well, because it really is, you know, fossil fuels and commerce. So, okay, I better stop. This is going to sound like a bit like a polemic on my part.
So I want to add that I absolutely believe, and I've written in the Lancet, in other journals, that and inspired really by the working with young people, that what they told us, you know, several years back, nothing about us without us. And I really believe that that is so important. So it's important to have children participating, being part of the shaping of the policies and the program that affect them directly, because as Professor Tomlinson has indicated, you know, there are presumption of what would be the preferences, and often those preferences do not correspond to, in fact, what children prefer. There are presumptions about what the impact of conditions, and that often that is also does not correspond. But most importantly, I think the agency that children have and their ability to actually protect and fulfill their rights is something that I think is unexploited, is not yet really reached potential. Like, for example, one thing that is really interesting in the field of climate change, you all will be familiar with the great movement that in the last 2-3 years we have seen initiated by children and young people. And Greta Thunberg is maybe the most known, but I have met and and seen in action many children from all different parts of the world, the low and middle income countries as well, and the high income countries. And they have organized in a very structured way that they call themselves the Yango Group, but also they have organized in many countries, for example, to support litigation and cases. For example, in the Netherlands, a group of children have challenged really their large corporation that is involved in fossil fuel extraction, and they've constituted themselves as a party to challenge that. And in fact, there were other parties that were challenging the case for oil extraction, and the court judged that the children were the ones that were the most appropriate to challenge, because oil extraction and fossil fuel production was actually threatening directly their livelihood in the future. So I'm using this as an example because I think that really working on the agency of children, not just as recipients, but also seeing what is the ingenuity and creativity that children have and the power that they have also when they speak up, I think is definitely a way forward for the future.
Thank you so much, both of you, for your really strong comments there on enabling children and also helping them actually step up and express their voices, and not just express their voices, but also take action. We've got another question which I thought would be really interesting to discuss. In light of Professor Tomlinson's comments on poverty and intergenerational trauma and how that affects children's well-being, and also keeping in mind Dr. Bustreo's slides on childhood poverty, 150 million, 140 million. Do the speakers have any thoughts about the end of, so some context, in the UK, there is a £20 weekly uplift to universal credit. that's ending very soon. And do the speakers, the both of you, have any thoughts about how that impacts families, households, and the likely impacts of vulnerable children? And on that subject, is there anything child health professionals can do?
Well, I think it's highly important for a healthcare professional to talk about the impact of poverty on the well-being of children and adolescents, because our voice as healthcare professional is often heard by the policymakers in a different ways, because we are, we have the knowledge, we have studied this phenomenon, we have the arguments. When we argue, we advocate, we don't argue just based on our feelings we really argue on the science, on the data, on the evidence. So I think number one, it's important for the child health professionals to be a voice and spotlight the impact that poverty has on children's well-being. And number two, I'm not familiar of the details of the, the £20 weekly universal credit, but as I said, I have not studied that, but as I've said, we have evidence from other countries in the world where the so-called universal or conditional cash transfers have had impact, particular impact on child health and nutrition and on women's health. But there are some conditions that have to be, that are important to stress. Number one, that they are appropriately targeted, so that they are not provided to families that do not have a need. Number two, that the cash is provided in the hands of women, because there are a lot of studies that show that actually women are better at handling those resources for the benefit of the family. And number three, as I said before, there is strong evidence from Latin America especially that attaching some kind of conditionality to those cash transfers that are linked to access to school, access to health services, access to immunization is in fact a vehicle for having the health gain that those conditional cash transfers are designed. So I'm not familiar with this credit in the UK, but it sounds like it's more like a universal credit welfare for poorer household. And so it might have less impact on child health, but it might still have some benefits for maintaining the family from falling below the poverty line. So those are the aspects to look at. And as I said, please add your voice as child health professional to the impact that poverty has on child health. That's always important.
Maybe I can just say I agree with everything that Flavia said. If I could ask like pediatricians like you anything, it is to remember that if you're involved in child health, you at some level are involved in politics.
Yeah.
Because if you're working in India, for example,
yeah.
and you have a child that's for some reason stunted, but actually you've been tracking it and you realize that actually some of the diet hasn't been that bad, but the mother seemed to have improved her diet from the next generation. When you realize that the nutritional status of the grandmother is often a better predictor of the grandchild because of this intergenerational thing, you're immediately into much more than just the diagnosis of stunting. Mm-hmm. You're into a whole lot of other things. And so that capacity to think about families, to think about the stress that a mother is often going through if there's alcohol in the family and that there's violence, and that it can, it's never just about the illness. And I think that's why I put that book out, because that book is fundamentally it looks at evidence, it believes in evidence, but it's actually saying so much of this is political, and so that would be my plea is none of I don't know, you're not going to solve child poverty in Scotland in the next 5 years, but the capacity to make those links, I think, can actually be profound, profound if there are enough medical professionals doing that.
Thank you so much. I think it's really important to, I really like what you said about how if you're in child health, it is political. There's a really political note there. I think a really long-running intercurrent theme throughout both of your conversations and this conversation as well is the fact that UBI, or basic credit or cash injections, are deeply political and deeply divisive. And pediatricians and health professionals have a lot to do and to engage in the politics of this. Thank you both so much for the very, very insightful words, the encouraging, deeply shocking, and also deeply thought-provoking statistics and facts and insights. I'm going to hand it over to Rachel now to talk a little bit about what could be our next steps and what might be our next steps. Over to you, Rachel.
Just again, extend my thanks to the two speakers. And behind the scenes, as well as on the chat, we've got 5 WhatsApp groups on the go, and everyone's really inspired and thinking about, we're writing quotes that you're saying and what we're saying in our next webinar. And so I just want to say, yeah, thank you so much. And just, I guess, for the participants that are still with us, thank you also so much for staying to this end point, because I think I don't want this bit to kind of be a tag on. I think this was kind of this part, and the course to action was kind of the reason we wanted to host these webinars, because I think almost all allied health professionals and people kind of health want to learn, but it's how kind of, into some actions can feel really overwhelming. And I think this is a really important part of our job, as kind of Mark and Flavia have alluded to, that we can have the knowledge, but it's how we use that. So I'm just going to share a few calls to action. So these are a few points that I've picked out of both of the presentations. Just a few things that as participants and ICHG members and committee members, really small things that we can do to advocate for children in this sphere that we've been talking about. So all of this I'm going to share in an email tomorrow after the presentation, so please don't feel you need to write it all down, but just to share a few of these thoughts. So one of them was, Flavia mentioned the PMNCH call to action report. There's actually some beautiful infographics, and it's a really readable report. I've read it, and I think just sharing that on social media, I think we need to be honest about where the future is going, and not only are children on social media, but child healthcare discussions on social media. So it's a really valuable platform, and I think some people, pediatricians, doctors generally, can be quite hesitant about using it, but we have a really important voice, and we have a lot of credibility, and so I think sharing really important, valuable resources is something that we can do. And the PMNCH also has a really exciting sounding events with some amazing speakers on. So I just wanted to plug that as well, because advocacy starts with us learning more and sharing and being inspired by each other. So I thought those would be some manageable calls to action. And then both Professor Tomlinson and Flavia mentioned the Children in All Policies kind of campaign. And again, we've talked about the agency of children and their families so much, and this kind of encapsulates all of that. So again, following them on social media, it's quite a new initiative, and they have a newsletter that you can register to. And we all get lots of emails in our inboxes every day, but I think, again, information is power, and knowing how to advocate and joining campaigns like this can be an easy step. And they're really, really interested in getting children. And so I think we all come into contact with some amazing children and some amazing adolescents who often are feeling unheard. And I think knowing where we can signpost them to is a really valuable part of our roles and responsibilities. So again, I'll share all of this information in an email to follow. But I think this, again, is something as allied health professionals we just need to have in the back of our mind and in our arsenal if we maybe meet children we think would be valuable in this kind of setting. And I try to stay away from UK too much because we've got a really mixed audience, but regarding the mental health kind of component of the talk, I thought it was really amazing that Professor Tomlinson was talking about, I think everything in the media at the moment and our experiences in A&E are that the presentations with mental health are significantly increasing, but it was really interesting to hear that counterpoint about actually some children making their lives better. And again, that's just a really interesting point that I took from the speeches today. But there's this absolutely fabulous mental health charities in the UK, but Young Minds is an advocacy charity that is absolutely keen on engaging children and adolescents under 25, and they've written a phenomenal open letter to the UK government, and they have some very clear demands, and these seem really reasonable demands about having some youth hubs and about, again, using media and digital media, but ways in which that they can engage at an early time when they're feeling that their mental health is suffering. And I think it's really powerful that they don't want, you know, adults to be signing it. They want this to come from the children themselves. And so again, if, you know, we're all allied health professionals, so some of us have desks and posters and boards which children see when they're either in the waiting area or if they're in our offices. So I just wanted to implore people to follow this really amazing charity, and also to signpost children to this open letter to the government. I think it's really worth a read, and even if you're not under 25, they have some other calls to action for us on their website. And then the final point I just wanted to make, we mentioned about poverty a lot. This is specifically for the London contingent, so I apologise, but I will just also add into the email. There is some amazing public health work happening in London around kind of signposting families and children who are in poverty to essentially poverty resources. So, you know, to healthy school vouchers, to kind of vitamin D supplements, to after school clubs, to free school meals. And so a lot of advocacy is giving agency back to the children and their family. And so I think signposting and understanding what resources are out there is really important. And there's been a big bit of work in London that one of my colleagues has done. I will ask if I can kindly share those resources, and maybe a call to action for people in other parts of the UK maybe to compile something similar that you could share with your families who are suffering or on that poverty line. And as we've talked about, that's going to be an increasing number of people in the UK and globally in the coming months and years. So I just wanted to add that on, and I will put it in our calls to action email that will follow. And I think with that, timing wise, we've done pretty well, and just want to again thank everyone who's still with us. I really want to thank Adriel, who chaired this, who did a phenomenal amount of work behind the scenes to get our speakers today, and also just again to our speakers. This is the first of 3 webinars. The next one is on October the 19th. Again, I will send it out with the calls to action email, and this one's going to be super interesting on food insecurity and malnutrition. We have speakers that are going to give us a global overview. We also have speakers that have worked in humanitarian crises, and we're also going to focus on food poverty in the UK as well, with some meaningful call to action. In November, we have another webinar on refugees and migrant health, which will be hosted by myself, which I'm really passionate about. So we're hoping that they're going to get bigger and better. And we really hope that, as well as being really interesting, we're trying to introduce real advocacy to child healthcare professionals, and we would value any feedback, any emails. I think all of you have my email from the invitation I sent out, so please reach out if you're interested to join the International Child Health Group, and yeah, we'd welcome any thoughts and comments, but otherwise I'll let everyone escape for dinner.
Thank you so much, everyone. Thank you once again to Professor Tomlinson and Dr. Bustreo. Final point to anyone that's still listening: we will be making the recording of this available on YouTube, and we will email the link out and spread it on social media as well. All right, have a great night, everyone, and have a great afternoon for anyone else.
Thank you so
Thank you so much. It's very encouraging to see the initiative you're taking. Thank you. Thank you.
Thank you.
Continue. Bye.
Bye.
All right. Bye, everyone.